Medicine, USA. So he will talk on coronavirus disease infection control in healthcare setting. Yes, please, Dr. Zahangir Khaled.
Okay. Thank you for having me here. Can you hear me?
Yes, we can hear you.
Yes.
So,
yes.
yeah, corona is a big burning condition throughout the whole world. I'll just go and talk few things on corona from where it started. The end of 2019, a novel coronavirus was identified as the cause of a cluster of pneumonia cases in Wuhan province in China. And then it rapidly spread in China and it becomes an endemic. And then from China, it spread all over the world. In fact, cases has been reported in all continents except Antarctica. There's the only safe place for not to have the corona. And in January of 2020, WHO declared corona is a public health emergency. In February, they designated the name of this virus as COVID-19, though the full name of this virus is actually acute respiratory syndrome coronavirus 2. And then in March of this year, WHO characterized it as pandemic. So next slide, please. Coronaviruses are RNA viruses. The coronavirus which causing this COVID-19 has similarity to two of the bat coronaviruses. So it sounds that the bat is the primary source of these viruses, but whether this COVID-19 transmitted to human directly from the bat or through an intermediate host is not yet clear. But if we look at it, throughout the worldwide cases of COVID-19, I know and the like PowerPoint, it is the August 11, actually by August 13 today is actually 20.2 million cases. And USA, the cases is right now is 5.23 million. And then next come to the Brazil, 3 million, India, our neighbor countries, that is a 2.27, followed by Russia, 900,000 cases, and South Africa, 564,000 cases. Total death throughout the whole world is 750,000, and only in USA, 165,000 people died from the COVID. And when you look at the statistics in Bangladesh, officially it shows 264,000 cases, and death is 3,400 death, 3,471. But I think that does not represent the real number of the cases in Bangladesh. It has multiple factors. One, lack of availability of the testing. Second thing, many cases the test was not perfect or falsifying testing, so it contributed there. So real number likely much higher. And there is a small studies came out from somebody did in Dhaka, where they do the antibody testing. About 8% of the people came out, some small areas in the Dhaka who had these viruses. So the real number will be really, really high. And the other issues in Bangladesh is the only country where the highest number of the physicians died from the coronavirus. And that is really sad. And can I go to the next slide,
yes,
please?
Yes. Okay, this is the next slide.
Okay. Then how this corona transmitted? The transmission is direct. Person-to-person transmission is the primary means of this transmission. The mostly happen with droplet respiratory secretions, like if somebody in close contact and the persons have the corona cough, sneeze, or talk, then this droplet can go to the other persons. We need to remember it needs to come in contact with the mucous membrane, where this RNA can work. If it goes to the skin or the body surface, it lies there for certain hours, then die. That cannot. That's happened. Then infection also occurs if person's hands are contaminated with the droplet by touching, contacting the surfaces, or then touches his eyes, nose, or mouth. And droplets typically do not travel more than 6 feet. That's why the social distancing, which we following for the whole world, is a 6 feet distance that came from there. And interestingly, it has been detected in non-respiratory specimens like stool, blood, and ocular secretions and semen. But the role of these sites in transmission is still uncertain. And the other things needs to be noted that when a person has the greatest infectiousness, it is actually 2.3 days before somebody developed the disease. It started from there, and highest is 0.7. That means the day before the disease. That 12 hours time, about 16 hours time before they develop the symptom, and then it can go up to within the 7 days. So that's why in many cases, when they are most infectious, before even they are symptomatic, that is one of the things. It is difficult to identify every case, then it is spread very easily. If you look the trend in New Zealand, they eradicated it. And then 2 days ago, they found 1 cases, and today from 1, it is 11 cases. Look at the Australia. It is an island, they enclosed, they stopped the travel and everything. They did better. Then 1 or 2 cases left over from there. Now it becomes, endemic. So now they are putting curfew in Melbourne area. So that's why many of this time, this, greatest, transmission time may, hard to pinpoint. And that is one of the reasons for this aggressiveness or easily, spreading of this disease. Can I go to the next slide, please? And the risk of transmission depends on the closeness between the person and the who has the sickness, duration of contact, and not use of preventive measures. That is the most important. And if you see the most secondary infections, who get, if the source is there, who get the disease easily, among the household contacts, they are the most vulnerable. Then in healthcare setting, when personal protective equipment are not used or improperly used, or those protections are defective, that put them to higher risk. And individuals are residing in a close quarter. That's why you have seen a lot of cases in the cruise ships, in jails. That is happened. Then the social and work gatherings, another place where it can easily spread. But there is an interesting study came out in Singapore, where when a patient was in an isolation room, and after with the COVID-19, after that they checked several areas of this room for the viruses, like door handles, light switch, bed, handrails, interior door, windows, toilet bowl, sink, basin, and interestingly, every places those viruses was found. This was done before cleaning, and after cleaning, when they did it, then those viruses is gone. So this is very interesting. So many cases, it can spread from those areas even we don't know. Like somebody else is using the elevator who has these viruses. After that, I'm going to use the elevator and press the elevator button. I'm getting it from there. Somebody and push a door, and I am using the same handle. I can get it, and if I touch my face or mouth with that contaminated hand, get the disease. So that is one of the biggest problem to pinpoint that which area is infected in the hospital setting, which area is not. And next slide, please. And in hospital setting in USA, which we are doing it, see, anyone who is the patient who needs to be come to the hospital, if we know this patient is coming, they are usually screened. It is done by phone. If they are not coming to the emergency, they are coming in other cases, even they are coming for the X-ray, even they are coming from the ultrasound, or even they are coming from any other, minor procedure. They are being screened over telephone. They usually ask for fever, cough, myalgia, sore throat, dyspnea, anosmia, and also recently reported diarrhea could be a presentation, and skin rash. And also ask all these questions. If any patient reported they have a fever or any of the symptoms, they are being told not to come to the hospital or the healthcare facility. They directly refer them to a actually respiratory clinic, which are dedicated in the management of this COVID patient. Those patients are being evaluated there to see whether they have COVID or not. And then all patients like screen, even the patients after this screening over telephone, or they are coming to the hospital, they after coming there, then the second time they are being screened for respiratory symptoms, fever. If somebody has respiratory symptom fever, they are actually put in the separate waiting area to prevent spread of this disease to the other patient. And then all patients without the symptoms, even somebody does not have any symptom, they routinely ask some questions like whether they have any unprotected exposure. This is important, not protected, unprotected exposure to COVID-19 patients within the last 14 days. If they have any exposure, then they also put to separate from other patient. And then the other things we are doing it here is the visitor restrictions. All visitors who are entering into the facilities, they are restricted. And now for the children or somebody coming for the delivery, only one person visitors is allowed, no more one. And then for the healthcare workers, and every healthcare worker should monitor themselves for fever or the COVID symptoms like cough, myalgia, sore throat, dyspnea at home. And if they have any of those symptoms, they usually call and tell them, and they are told not to come to the hospital. And then employee health, they contact the employee health who make the arrangement to test them whether they have COVID or not. And in addition, when we come to the hospital, getting entry into the hospital, in the hospital actually they have two separate entry. One for the patients and their visitors, other one is for the physicians and other hospital staff, nurses and other auxiliary staffs. And everyone after entering, some staffs are placed there to check their temperature. This is a routine, and after entering. So, and this temperature is checked with a thermoscan that is non-touch to the skin, because it just put it in front of the forehead, it gives the temperature. In some places, they have thermoscan place. So as soon as you walk in through the door, thermoscan is showing the temperature. If anyone's temperature is 100 or above, they are told not to get in the hospital, just go home. And that's another way they are doing it. Next slide, please. All patients, sorry, when in the hospital or healthcare facility should wear mask upon entry into the facility. And there is no excuse for that. Visitors should be asked to wear the mask throughout the visit. And one patient goes to a single room. Now, due to the COVID, all rooms are, for the COVID patient, rooms are single room. They even, it was the double room, now they converted in the single room because they don't put two patients in one room. And once patient is in the room and the door is closed, then the patient can take off the mask. And then when the healthcare provider enter, is a doctor, physician, or any other one, they knock the door, and the patient should put the mask back on themselves. And if if a patient unable to do that, after entering to the room, healthcare provider first put the patient's mask, and then we'll talk. In that situation, they should, in addition to the face mask, healthcare worker also use the face shield. And if a patient cannot wear a mask, then face shield should be used in addition to face mask. And then healthcare workers should use the mask all time during their stay in the hospital or any office setting. And now that comes about the, like sanitize the hand. Hand sanitizer is done by hand sanitization or hand wash. Because when you do the hand wash, in many cases, hand wash is not perfect because it needs to be washed at least for 20 seconds. And how we do that? It is, not feasible every time you put a clock and then it is counting your, 20 seconds. The rule of thumb, we use it here. When we wash our hand, we count slowly from 1 to 40. And if you count that, it actually takes 22 to 24 seconds. So if you start hand washing and just count 1 to 40, when you see 40 is done, then it is 20 seconds passed. Then it is good one. Then when you use the elevator, as I told you, and that is one source, elevator button. And on those cases, actually, the two things we maintain it here. One, either you use a piece of paper to press the elevator button or any hospital door to open, and then throw it. That's one option. If a paper is not available, then somebody can use the hand, but when they come out from the elevator, they need to be sanitize their hand with hand sanitizer or hand washing before they touch anything. And other things is then when we put the mask, and it is very important before putting the mask, hand should be washed or sanitized. And when you put the mask, you have to make sure that mask is properly fitted. And even in the surgical mask, make sure there's no space between the nose and the face area, and is fitted. And before removing the mask, say you need to do anything, then hand needs to be sanitized also before removing the mask. That is another thing is strictly followed. And in office setting, like here, then we don't use the gown, but face mask and face shield is mandatory. And next slide, please. And now, among these things for the healthcare workers, for the protective equipment, we use the gown and the gloves, surgical mask, face shield, goggles, N95, respiratory mask, and powered air purifying respiratory mask and shoe cover. This, has been used. And among these, the goggles, it is not very effective as face shield. That's what usually, encourage the hospital encourage to use the face shield instead of the goggles because it covers the whole face, and that is more preventive. And then these N95 respirator, we will talk about. There's a certain scenarios where it's been used. And go to the next slide. So these are the things you put it, which is called the aerosol generating procedures. And if you look at it, that in addition, in orthopedic surgeries, there are also some other aerosol generating procedures there. And many of the patients who goes for under intubation, then aerosol generating procedure, bronchoscopy, or here is the cardiopulmonary resuscitation. They also put the colonoscopy. Then who is on nasal endoscopy and on ventilator, open suction of the airway, and tracheostomy, upper endoscopy, and swallow evaluation. These are the cases which is the, we as a physician or other hospital healthcare workers are highest risk. So this needs to be looked very, very carefully, and we have to look at what we can do in this situation. Next slide, please. So for all these aerosol generating procedures, it is a standard to protect the healthcare workers, follow the airborne and contact precaution with eye protection. You see airborne contact protection, and that means use the gown, gloves, goggles or facial, but facial is preferred, and then N95 respiratory mask and the shoe cover. But here in USA, we are using a lot of PARP. There's a power air purified respirator. This has extra benefit over N95 respirator mask, because even with the N95, you have to put the face shield, and especially those who wear the glasses, and it makes the fog. It makes the face shield and the glasses foggy. But in power air purified respirator, and there is a picture there, you can see that this is actually, if you put it in your head and then it covers the whole face, then you don't need another like mask or respirator to wear inside. And when it is turned on, it actually blow the air from the back, and your face and everything is covered, does not need extra face cover, and it blow the air. As the air is blowing, there is no fogging, so your glass will not get fog, your breathing, nothing is the fog. Actually, it is more appealing here, and we use that, surgeons use it more. And the picture is there, there is the first generation, and the new came out, which actually does not have this big, tube which goes in the behind, because they have an rechargeable battery installed right there. This is the old generation. We have this one also, new one. This is like, you can see those tube goes in, it actually tied around your in your tummy. It just tied around your belt. So, and turn on it, it blows the air from there. New generation, it has put it on the back. There is a small motor, which is a powerful, and it is either rechargeable or battery operated. And you press it, and it just one single piece. You don't have no attachment, other things. And we use this more than N95 in the aerosol generating situation. And the other things to remember, that after a aerosol generating procedure, and if it is a negative airflow room, 30 minutes, again, it is 30 minutes after the procedure, if it is not safe. So somebody entered to that room or is staying there, they should not take it for another 30 minutes. But if it is a regular room, it needs to, time is for 2 hours after the procedure. It is still having a chance. So it needs to be, keep this protection up to 2 hours if they are staying in that area. Next slide, please. Now it comes about some emergent procedures I mentioned. If patient is coming to the emergency and their COVID-19 either is known or suspected, then what you will do? And in these situations here, not one, actually two physicians, this is called the risk versus benefit assessment. Two physicians discuss about the risk versus benefit. If they feel this will be more risky, then they decide not to proceed. If both the physician, for the patient's benefit, this need to be proceed. If they got the proceed, if it is done, need a local anesthesia, then the physicians and other nurses and surgical techs who are in the room should go, anesthetists should use droplet and contact precaution with eye protection. And if the general anesthesia, the same, airborne and contact precaution with eye protection. This is for emergent. What we do here for elective procedures, like a patient is not emergency, they need to come for the elective procedure, any elective, orthopedic surgery procedure, or it could be general surgery procedure, or it could be endoscopy, colonoscopy, anything. And on this situation, actually, all patients are screened for COVID-19, and that is actually not the antibody testing. There's a PCR-based testing, 24 hours before the procedure. Sorry, 3 days before the procedure, not 24 hours. And the result of the test available within 24 hours. And since the test is done, patients are told to go for self-isolation at home. They should not go to any outside or anything. And if they follow that and the test is negative, then go ahead and do the testing. If they don't follow and then the tests come back, then the procedure is canceled, or even test positive, then automatically is canceled. For example, I can give you, recently you heard about a lot of issues here with the Black Lives Matters, a lot of movement. When that happened, there is several patients in the hospital who get the tested, but they went to the procession in favor of the Black Lives Matters. On that day, in the surgery area, 80% cases are cancelled as they don't follow that self-isolation. And that is for the safety of the healthcare worker. So, and in addition, I can just tell, so far, there is no, preventive medications which the healthcare worker can use it. But you see due to the news, some physicians, but that is not well studied in their own choice, do use hydroxychloroquine as a prophylaxis, but it is not well proven. That's why it does not officially, recommend to take by the healthcare workers as a prophylaxis. So I will just end there because and then I'll take the question.
Thank you, sir. Thank you for your nice presentation. And it was a magnificent presentation. Lots of new information we got from you, especially about the respiratory mask and the time of operations. That is very important for us also. I would like to request our honorable audience, do you have any questions regarding this? If you have any questions, please, you can ask. We have 10 minutes for discussion about this topic. And after this, we will go for our next topic to Professor Hasan Masud sir. And now its floor is open. You can ask about anything COVID-19 and the healthcare worker safety purpose. Yeah, Hasan Masud sir, you have to unmute yourself.
Yes.
Dr. Khaled Jahangir,
Sir,
Yes.
sir.
what is your latest situation in your state, Illinois?
The latest situation, it was coming down in the late May, and then in the first part of the June, it improved. Like total number of the cases was down to about 500. And then since this Black Lives Matters, those movement and people, when they go to the procession, they don't follow the social distancing. And then it is now like, this is a time school is off, many people go for the travel, especially the Florida is really bad. And they're coming back from there and getting it. Now that number is rising. In last 24 hours, there are about 1,200 new cases in Illinois, which was one time it was less than 600 a day.
What is the condition of the school, college, and university? What about the education?
Educations, okay. And here, some schools are going to do the online courses, and some open, but only limited number of classes. For example, my nephew goes to MIT, and he is having one class a week. One class a week, just think about it, in personal, on person, and rest online. But they need to go to the campus because in once a week. Then my other nephew is going to the Yale, it is the same, 2 classes a week physically, and rest online. And University of Illinois, the medical school, those on the basic science, anatomy, physiology, pharmacology, all online. Because what we do, we download the lecture for the clinical rotation. Those are, third and fourth year students, they have to become for the clinical rotation.
Okay. Okay. Jahangir, I want to ask a question, Jahangir.
Sure.
Jahangir, can you contribute something for us in on the ground of medical science in Bangladesh? Contribute
So what?
Online contribution. That is your education contribution in for us.
Oh, that can be done, definitely. I'll be happy to do that if there is a platform there.
Because a lot of misconception are prevailing in Bangladesh regarding issues of COVID. What is your opinion?
I do agree with you because part of it is, like it is vague ideas, and then part of the things is by media, or especially the social media, and anybody can tell anything. And like here, we at least have something we call the CDC Center for Disease Control, or FDA, Food and Drug Administration, who can definitely tell, okay, this is what you are trying, this is the medication you're trying, it is good or it is not. And in Bangladesh, anybody can claim it, and there is no authority who is looking on it and telling it, it is right or it is not right. That is the biggest thing. And
thank you, sir. Thank you. Thank you for your answer.
Yeah.
So we have a question from our audience.
Yes.
Yeah. Hasan,
one question. Yes. One question from Dr. Sanjay Sinha. How many deaths are there in Illinois state? And one question from me. You have mentioned about PAPR. So I have seen one plastic surgeon in a private hospital is using PAPR for the surgery. And what is the cost of PAPR?
I can check the cost. Yes, I can check the cost.
Okay.
And for you, and the exact date I can just just go to from this screen. I can tell you exactly how many days in Illinois. Just for a second, I will just go out of this screen to look at it. Okay.
Okay. And I would like to just put one question to Dr. Sanjay Sinha. What are the aerosol generating procedure in our orthopedic surgery? Can you speak, Dr. Sanjay Sinha? Can you tell something? Dr. Sanjay, can you hear me?
Sir, I cannot hear properly, sir. I think my network is good.
Okay.
So I give the questions in chat box.
No problem. And Dr. Divakar? Dr. Divakar, are you here?
Hello.
Hello. Dr. Divakar, please unmute. Dr. Divakar.
Yes, sir. Hello, sir.
Yes, I would like to ask you that what are the aerosol generating procedure in our orthopedic practice?
Mainly, sir, in our orthopedic practice, when we use in OT in
Cauterization.
Yes, sir. That is one of the most important factor of aerosol generator, mainly in OT. Other than when we use the electric saw, it will also cost aerosol generating procedure, so that we should take some precaution mainly in our outpatient department or outdoor.
Okay. And another also suction, is not it?
Yes, sir.
Suction
Yes,
or pulse lavage.
Yes, sir. But in it is an international protocol in using cautery, that when we use the cauterization, we should always use suction in that condition, and as much as low pressure we have to use in cautery.
Okay.
So I have the answer for that. In Illinois, there is total of 7,900 deaths.
7,900 deaths.
900 deaths.
Illinois
total
state.
cases, yes, total cases are 201,000. That
Okay.
is the statistics until today.
Okay.
One more question.
Can I put a question to
Yes, sir.
Zahangir Khaled?
Yes, sir.
Sure.
Yes, please.
Yes.
You in your country or in your state, is there any antibody test? As because most we know the most of the COVID are symptomless, and we thought that most of our surgeons and people are already affected, subclinical or without symptoms. So if we test the antibody, we can easily handle the patient. Is there any?
And antibody testing is available. They are doing it, but the real issue with the antibody, when you do the antibody testing, that may not tell you whether the patient has past infection or ongoing infection. It might be an excellent resources to see how many cases in the community, but in a surgical situation, when you need to know a patient is coming for the surgery and you consider your safety, then if there's the things like this patient may have the, like the COVID testing done, antibody came back, it may be the past infection, it is not happening infection right now. That's what they are recommending here, to go for PCR-based testing for this situation.
I think for us, we are medical personals.
Yes.
We can test the antibody, and if is there any immunity to us, we can handle the patient less cautiously.
Okay, that's the excellent questions. But if you know that the study have shown the antibody lasts for 4 months. After 4 months, somebody can get reinfected. That is the biggest drawback.
Okay, thank
Yes.
I can put a question.
Yes, sir, please.
Hello. Yes.
Yes.
Thank you, Dr. Zahangir Khaled, for your nice presentation to the healthcare like us as well as general population. My question: when we go for routine OT schedule, I advise COVID-19 for patient and do it and back to my hospital for routine OT. But if patient come after 48 hours or 4 days after the test of COVID, because patient give the blood, but in our situation, it takes about 72 hours or 48 hours to get the result of COVID. So what will I do in this situation?
Is in a tough situation, but which is done here, say if you say, then if you presume that okay, this is the patient who has COVID, then you have to be protective. Like with the COVID patient, then if you do a procedure, if it is do a aerosol generating procedure, then you have to take full precaution. Like as we talk about the last slide, if you go and look there, that you have to use the airborne contact precaution and also eye protection. You have to do full to keep yourself safe. And at the beginning, some of the physicians here, they use the N95 mask, on top of it put the surgical mask. That this practice now is going like this. But if we look at the hospital where I work, they have more than 160 physicians and other stuff. Among all these groups, only 3 physicians get COVID and couple of nurses. That's all. But nobody died.
Yeah.
This is all from this precaution.
Can I, to exclude COVID, any high resolution CT is effective in this condition?
It can. CT shows some specific chest findings. Chest findings that actually, if you look some of those things from the New York, In early cases when the COVID was coming, like somebody came from the road accident and they did the whole body CT, chest findings, tell that patient most likely has COVID. And then they do the COVID testing, it came back positive.
Thank you.
And it is possible. There's another thing that you mentioned. And if this COVID patient goes to like suspected or or known for the CT and other thing, that needs to be all this technician and who will take the patient to the transport team, and everybody have to take the full precaution. That include full precaution when they're moving this patient and taking in and out.
Thank you.
Okay. Dr. Tanvir, there are another 2 questions in the chat box. So whether Dr. Zahangir Khaled will answer these questions or he will answer through chat box.
Sir, I think time is going on.
Okay.
So we'll go for our next presentation. But before that, I want to ask a question.
Yeah.
Honorable Secretary, sir. This question was asked previously by Dr. Sanjay Sinha. How many doctors died in your state, sir?
In Illinois,
Yes, sir.
and I think is from the COVID 2 or 3 in Illinois.
Only 2 or 3.
Yes, even the highest when is the highest impact in New York. They've only 7 physicians died. Even the New York, when it was so many people that died.
Is it the number of physicians or total patient?
It's the physician. I'm talking about the physician.
Okay, physician.
Total,
Okay.
yeah.
Okay.
Yeah, this is the physician because that is for the physician side I'm talking about.
Yes. Dr. Zahangir Khaled, there are 2 questions in chat box. Would you please just answer these questions through chat box?
Okay, I can send it. And basically in USA, if you look at the USA, there are death in USA actually a lot. In US, it is more than 165,000 people died in USA.
Yes. And
but compared to that, if you see the total number of the death compared to the total number of the COVID, it is the highest in the world, 5.2 million. But number of the death of doctors, nowhere close to those who died in Bangladesh.
Okay. And Dr. Jahangir, another question in chat box. Every time we have been suffering from this question. Is there any option to reuse the N95 mask?
Yes. N95 mask can be reused if supply is not enough. When you reuse, you have to keep it in the safe area, and also you can do there is some arrangement how you can sterilize it. Sterilize it, and then you can use it. Even with the gown, say we are working in some places where if the gown is not contaminated due to the lack of supply, when supply is less, we have been told not to change the gown. You can use that gown. Wear it, because if it is not contaminated, if it is contaminated, no question, you have to change it.
Okay.
Sir, what about the sterilizing process of N95 mask?
Plasma sterilization.
Yes.
Sterilization or spray.
Plasma sterilization is the better option for
the best way to do it. They also use some ultraviolet.
Yes, ultraviolet.
Plasma sterilization.
Plasma sterilization is better.
Best.
Yes.
I have a question regarding the use of your mask, N95 mask or your gown. If you keep it for 5 days or 4 days after that, it's told that after 5 days to 7 days we can reuse it. Do you agree on that point?
No, we usually, even with the reuse it usually done. There is a time when there's a lot of sudden drop in the supply chain, then it will use up to a week. But we usually, when we use it 3 days or 4 days, then we'll throw it out.
But if
And
you
this
do
is
2 times, 3 to 4 times, or
no
after,
3 days or 4 days, then just throw it.
or then throw it.
Throw it.
Okay, okay.
Yeah. And the
Regarding
surgical
surgical,
mask,
yeah.
surgical mask which you started, like I started today, this morning, as soon as I come in, I get a surgical mask and I will wear it the whole day, and at the end of the day I will throw it.
That is a surgical mask. We are surgeon, we know it. We are always
Yes.
throwing it one after another. But regarding
Yeah.
this N95 mask or the costly masks are not available.
Available,
We are
right.
using it after 3, 4, 5 days, reusing it. As I am my
Right.
concern, as I am not dealing directly with the COVID patient, so I
Yes.
think it is better to use it, reuse it. And regarding aerosolization, what is my theory? What I have heard from Indian specialists that, I mean, opening the windows
Yes.
and no closed door procedure should be done. Even COVID patients, COVID surgical patients,
Yes.
in the windows or negative pressure, the ventilation, that is mostly, I mean, favorable for our surgeons or surgical staffs in operating these sort of cases. Do you agree on that?
That I can tell, to be honest with you, because most of the OR here, you don't have any windows. Yeah, so what? Because you get it, OR is a closed section here. Like
Close
it is,
tight, yes, that's
yeah,
right.
if it is started one side of the corridor and go other side another corridor, it is in between. There's no window.
No, it is said that if a window is there, extract the air outside, that is good for the, I mean, this aerosolization will be less,
Yes.
the virus load will be less, the surgical team will be less affected.
That it may be, but on the same time, when you open it and you let it go to the outside, you have to also look for it. You know, many places the hospitals are congested who are living next to that. And when we are doing this droplets to the air down there, so some other people around there, they may be
Not
getting.
inside, not inside. They are
No,
telling that you take the air outside. I mean,
no, outside,
open
like
space.
this.
Yes.
Right.
Okay, thank you very much.
Okay.
Thank you, sir.
Welcome.
Thank you for
All
your
right.
nice presentation. Thank you, Jahangir
Okay.
sir, for
Thank
your
you.
presentation. I would like
Okay.
to request Dr. Hasan Masud sir to start his topic presentation, and that is.
So thank you, Dr. Tanvir, and very good evening to honorable panelists and learned audience. So I will be talking on components of total knee replacement. So here is the history from Gunston in 1960s to the modern knee like attune knee or PFC sigma rotating platform high flex knee. This is a nutshell the evolution. I will not talk that. But now about the implant choice in total knee replacement. What are the criteria? The implant should have low revision rates. So we are concerned about the longevity of the implants, high satisfaction to the patient. Also, it may be cost effective and availability of the implant in that region. And amongst others, like there are also surgeon's choice and also according to the specific need of the patient. So during the choosing an implant, biomechanics should be near to native knee. It is not possible to achieve full biomechanics in the total knee replacement like the native knee, but we try so that we can get maximum biomechanics to the native knee. And for that, three things are needed. One is conformity, another is constraint, and another is kinematics. And what is conformity? Congruity of the articulating surfaces in which the concave polyinsert conforms to the convex femoral component. Configuration to different motions, usually rotational or translational. And third, the kinematics. It is the geometry of motion, depends on the degree of conformity and design of the constraint. So three things should be bear in mind: conformity, constraint, and kinematics. And now, if you divide for total knee, there are three components: femoral component, tibial component, patellar components. But we are not doing the replacement of patella sometimes, but I will discuss on it also. So there are variation in femoral components, there are variation in tibial components, and there are variation in patellar components also. So variation with regards to femoral components, there are many designs. One, the common design is box for post and cam mechanism. It is for fixed bearing knee and rotating platform knee, which I will be discussed. See here, this is a knee with box. So for box, it is needed to do a cut in the femur, and there this is also cam. And here see, there is a space in the middle of the femoral component, and there is no box, and it is used for cruciate retaining, fixed bearing knee, or rotating platform knee. And if extender needed, then it should be inserted. And now the cruciate retaining femur. See here, there is cemented and also the cementless options. And now come about the radius controversy. See, there is multi-radius of curvature. See, here is the single radius of curvature, and there is gradual change in the radius. It is also called gradius. And more recent implant like Attune have this type of curvature, gradius curvature. So there is radius controversy, but a paper from India showed that single radius total knee replacement implant designs are theoretically claimed to overcome mid-flexion instability and decrease quadriceps loading encountered in multiple radius designs. However, limited or no data is available to support single radius over the multi-radius designs, especially in Indian population. And there is also other paper, like from a paper Stoddard et al., the kinematics and stability of the single radius versus multi-radius femoral components related to mid-range instability after total knee replacement. It also shows that significant differences are not found between the biomechanical behavior of the two total knee replacements. And now come about the bearing surfaces. See here, the femoral component, it is of cobalt chromium. Another component, see, like black, it is oxynium, that means oxidized zirconium. And another, that is golden knee. Some company like Merrill or others have this type of knee, golden knee. It is of titanium, niobium coated knee. So there are controversies in the bearing surfaces, but not so much differences. But one thing, that if it is titanium or niobium coated, this is more scratch resistance. Now come about the posterior stabilized knee, which is also called the PS knee. The posterior stabilized design involves sacrificing both cruciate ligaments. That means you have to sacrifice anterior cruciate and posterior cruciate ligament. It has a cam mechanism which reproduces the combined rolling and sliding movement of the distal femur over the proximal tibia. At about 70 degrees of flexion, the cam engages a central position in the tibial insert, avoiding dislocation of the femur during flexio extension. And see here, this is the intercondylar box. This is the femoral cam, this cam mechanism which I have told. And this is from DP, and this is from Insol Bernstein. This is also the posterior stabilized knee, which is called the PS knee. And so here there is cam and post mechanism, and insert is more congruent or disc. What are the advantages? Like easier to balance the knee and more range of motion. And what are the disadvantages? like the cam jump, post wear, patellar clunk syndrome, additional cut from the distal femur. And there are some paper which said that posterior stabilized knee gives better flexion range than the cruciate retaining knee. But also there are some papers where there is they show some difficulties in the posterior stabilization knee kinematics. Like Huang et al. Is described that increased stress concentration at the tibial part occurred at increased flexion angles along with axial tibial rotation. So more wear and tear in their tibial poly. And see here, there is in posterior stabilized knee, there is cam post where anterior and posterior can lead to polyethylene debris. See, this is the cam, and this is the post. When it articulates and there is flexion, there is also cam and post wear. So there is the poly wear. This is the polyethylene tibial insert, and also the femoral component design may lead to patellar clunk. And see, here is the PS knee and CR knee. This is the posterior stabilized cruciate sacrificing options. See, there is the post cruciate sacrificing means anterior cruciate and posterior cruciate both are sacrificed. So here there is cam and there is post, but it is cruciate retaining knee. That means here the posterior cruciate is retained. Anterior cruciate is sacrificed in both the knee. So here no post is seen, but here the post is seen, and here is no cam. So here see the video, or the left side, this is the CR knee, and here is no box and no cam and no post. But here you see the cam and see the box and also the post. So this is the difference between the cruciate retaining and posterior stabilized knee. And now about the cruciate retaining knee. Cruciate retaining processes are implanted, leaving the posterior cruciate ligament in situ. Theoretically, the cruciate retaining design allows a greater degree of knee flexion. However, no conclusive studies confirming the supposedly superior performance of cruciate retaining designs have been published. And what are the benefits of the cruciate retaining knee? This maintains of the joint line. There is femoral rollback, proprioception, maintenance of a central contact point of articulation, and low shear stress on the bone cement interface of the tibial component. So these are the advantages. But what are the disadvantages? Like if there is tight PCL, so there will be increased PCL wear. If there is ruptured PCL, then there will be flexion instability. So the disadvantages of PCL preservation have historically been higher polyethylene stresses, a seesaw effect. See, this is the seesaw effect from femoral glide and difficulty in soft tissue balance, and the fact that PCL retention is not always possible. And to be honest, for the beginners, the posterior stabilized knee is more easy than this cruciate retaining knee. And see here, with an intact PCL in extension, the contact area is near the mid tibia, and in flexion, the contact area is posteriorly. So this is a rollback effect. And come about the tibial component. The tibial insert can be fixed or mobile. The mobile inserts available with both cruciate retaining and posterior stabilized knee have the potential to rotate slightly over the tibial component during flexion and extension. So this is the fixed bearing knee, or it is fixed to the tibial tray, and here the poly will be rotating on the tibial platform. So mobile bearing prostheses are characterized by high congruence between the femoral component and tibial platform, resulting in lower contact stresses since the load can be distributed over the largest area. So this tibial component, it is mobile bearing design. The poly rotates over tibial base plate. So there will be reduced poly here and also the bearing spin out. And see here, this is the fixed bearing knee. Here all it is the femoral cap. We can cement it to the femoral condyle, and this is the tibial tray, and this is the poly. And see here, there is only flexion and extension, no rotation, and here the patella glides. So it is the fixed bearing knee. It is, and see, this is the mobile bearing knee or rotating platform knee. See here, there is rotation of the tibia over the femur. So in addition to flexion extension, there is rotation of the component. So this is mobile bearing knee, or also called rotating platform knee. And why to consider the mobile bearing knee? Better kinematics, lower polywear, lower fixation stresses, self-alignment, more forgiving on malrotation. There is better patellar tracking, and also lower patellofemoral loads, and also higher flexion, and also the better patient satisfaction. So about the fixed bearing knees, there is monoblock like all poly CR, all poly PS, or all poly medial pivot. I'll show the picture in next slide. So monoblock may be also metal back. So one monoblock may be with metal back, or on a monoblock may be with all poly. There may be cruciate retaining, there may be posterior stabilizing, or there may be medial pivot knee. What are the advantages of fixed bearing knee? Like no back wear, no micromotion, and also this is cheaper. So here, this is the all poly in total knee replacement. This poly is introduced into the tibia, the tibial cut. There is no tibial tray. And what is the disadvantage of this all poly tibia? Cannot add a stem in it, and or OS cannot be introduced into it. And when there is infection in the total knee replacement, sometimes we leave the tibial tray but change the poly insert. But here this is not possible. So inability to change the liners in infection. And also there is another pitfall of this all poly tibia. There will be unequal distribution of force. So in severe deformity, we cannot use this all poly tibia. And here, see the difference. This is the all poly tibia. It is inserted in the tibia, and here is metal back tibia. That means there is tibial tray over which the polythene is settled. So there are also several sizes like 3, 4, 5, which is needed, should be inserted, and according to your templating, and come about the patellar components. 4 design articulates with all femoral components. There is choice of fixation methods like oval dome patella, round dome patella with central lug, round different types of patella. I will not be talking on that. And there are some special knee, like there are gender specific knee. For male, for female, there are different knees which is just invented by the Zimmer company, and also the high flexion knee prosthesis. See here about 150 to 155 degree flexion as claimed by the companies. So see the high flexion knee, but you must have the pre-op flexion of that type, like 150, 155. If you have pre-op flexion in patient at 90 degree, it cannot be rendered to 150 degree. And this is the constant total knee replacement. And the constant condylar knee was developed by Insol and colleagues from the traditional total condylar knee. It increases the depth of the femoral cam and enlarges the tibial post. Moreover, a femoral stem and a longer tibial stem are added to control varus and valgus stresses for improved stability. So it is needed for where there is collateral ligament instability. So constant condylar knee prosthesis is needed for the where there is collateral ligament instability, and also sometimes we use it in revision prosthesis. And there is another type of prosthesis what is known as hinge knee prosthesis. It is needed where there is global deficiency of the ligaments. The hinge prosthesis is an alternative model and is useful in cases of revision surgery. This design incorporates the longest femoral and tibial stems and central hinge, allowing flexion and rotational movements by means of a rotating platform. So, this constant hinge design, there is linked femoral and tibial components, and tibial bearing may rotate around the yoke. There are chances for aseptic loosening, early aseptic loosening. Also, large amount of bone resection is needed here. And there are other methods also, like it is the augmentation where there is bone defect. There you have to augment it by bone graft or some metallic component. See here this augmentation, and here this is the extender. It is for femur component and it is for tibial component. These are called the extender. So always think about the selection of the knee implants, because you saw there is a paper which showed that the 80% of the total knee patients are satisfied and 20% patients are not satisfied. Why they are not satisfied? One of the causes is to choose the what is needed for that patient. You have to choose proper implant for that specific patient, and there may be other factors also. And so the take-home message, what is that? If the PCL is intact, you can use CR knee if it is available. And what are the advantages? Like this: bone is conserved, no post-camp impingement, and restoration of the joint line, and improved proprioception. And if the PCL is not intact, like my next speaker will tell about it, like the rheumatoid knee, in that case, the bone is destroyed and also the ligaments are destroyed. So you cannot use this cruciate retaining knee. In that case, you have to use the PS knee. Or if you want to remove the PCL, then the PS knee, posterior stabilized knee. Additional cut in the femur, like the box cut, there is post-cam impingement, but easier to balance. So I have told already that it is the PS knee is easy for the beginners. And where there is collateral instability like varus or valgus instability, then the constant knee is chosen. There is more femoral resection. And if there is global ligamentous deficiency, then the hinge knee. Here, large amount of bone is resected. So thank you very much. Dr. Tanvir.
Yes, sir. Thank you, sir. Thank you for your nice presentation. That was highly informative, and that helps us a lot. Is there any question from our respected audience and viewers and teachers? If there is any question, you can ask. To
Yes.
Otherwise, we'll
Like two question.
Yes. Dr. Jahangir, please.
Number one question. What are your criteria for selection of the patient for rotating platform knee or mobile rotating knee? Can you understand?
Yes, yes. For the rotating platform knee, yes. If it is not very much complex knee, then you can use this rotating platform knee, and rotating platform knee has beneficial effect. Like it is more like the native knee, because there is rotation also, and in the native knee there is flexion extension and also there is medial and lateral rotation. So you can preserve the knee. So in in complex knee, complex situation you cannot use, but in the primary knee where the patient has not so much deficiency and the collaterals are intact, then you can use the rotating knee. But the cost is high, but you can use it. It is more beneficial, and it maintains the more the native knee. So more the mechanics, more the kinematics, more the congruity, and more the conformity.
Masud,
Thank you. Yes.
I want to ask another question. There are designs, there are short stem in case of tibial knee, and there is long stem, and there is exeter. What is the indication of different design?
Yes, if there is bone loss or additional stability is needed, then you have to use the long stem, and otherwise you can use short stem, or sometimes the inbuilt stem which is provided by the company. So in case of where the stability is needed and where is deficiency of the bones, or you want to revise the knee, that means revision knee, in that cases you have to use the stem, because you have to dissipate the forces to that stem, to the bone. Yes, sir.
Masud,
Yes, sir.
regarding this mobile bearing knee and this fixed bearing knee,
Yes,
so,
sir.
what is your recommendation about the literature? What the literature says actually? Literature.
Yes.
Do you have any idea about the literature?
About the mobile bearing
and fixed bearing.
fixed bearing knee.
And
Yes,
fixed
sir.
bearing.
Yes, sir. One literature by Ranawat, they told that rotating platforms were introduced as an alternative to fixed bearings in hopes of providing more natural kinematics and improved clinical outcomes. In vitro wear studies showed significantly less wear with rotating platforms as opposed to feet bearing design. That means there is less wear in the rotating platforms as opposed to fixed bearings. And kinematically, the rotating platform is more superior than the fixed bearing knee. But they also commented that these benefits have failed to translate into improved clinical outcomes or survivorships. Ultimate outcome is same. So it was a paper by Ranawat.
Yes, that is why I am telling this thing, because it was initially thought that mobile bearing would be the better outcome. But ultimately, like our bipolar knee, or you see the condyle uni, uni and bipolar the same.
Yes,
the result is not so many difference.
Yes,
so
sir, I agree.
Only the price is, yeah. Okay, okay.
Sorry, sir, continue. Sir, I can share something regarding mobile bearing.
Yeah, please go on.
Sir, some literature shows that is mobile bearing did some medial to lateral rotation, only limited degree, but provided you select the prosthesis for the patient who are adequate ligament balance as well as soft tissue, adequate soft tissue there. And it also indicated in the patient young, active as well as short patient. Sir, recent literature explain it.
Okay, Dr. Masud, one question to you from me.
Yes.
You said that in high flex knee, patient before operation, if he can move flex the knee up to 150 or 155, then if you use high flex knee, then she or he can flex knee 150 to 155. Why if a patient knee before operation is 90 degree and we use the high flex knee, why not more than 90 degree she or he cannot flex?
Yes, for the longer duration, there will be contracture of the muscles and also the surrounding tissue. So we cannot release so much. That is why it will not give the flexion like the 140 to 150, because there is already contracture in the muscles and tissue, soft tissue.
If we release the muscle and ligament by casting and others mean, also posterior capsule, why not more than before flexion can occur? I think
I think more than before, where
yes.
there is 90 degree, we can add it 20 degree to that, but not
Yes,
150
okay.
degree, right? 100.
Okay, thank you.
Yes, yes,
Thank you.
thank you.
Okay, thank you.
I think we are going out of time. So we will take questions in the rest of our presentation. Now, I would like to request our next speaker, Dr. Shivantha from Sri Lanka Teaching Hospital, Kuliapitiya, and his topic is replacing the rheumatoid knee. I would like to request Dr. Shivantha sir to present his topic.
Let me have a little introduction of Dr. Shivantha Fernandopulle. He is the orthopedic surgeon in the teaching hospital, Kuliapitiya, Sri Lanka. He is the secretary of the Sri Lanka Orthopedic Association. It is the Secretary General of Sri Lanka Orthopedic Association. Yes, please.
Thank you very much. Can you hear me?
Yes.
Yes,
Good,
yes.
yeah. Thank you so much. Thank you very much for the kind introduction, Professor Hasan and also Dr. Tanvir. Thank you so much, and it gives me great pleasure and privilege to join your webinar. I visited Bangladesh for the AO Alliance non-operative course in Dinajpur in February, which was the last AOA course that was held with physical counter interaction. And so I think since then, everything has been AO, has been on like Zoom. So I was, it was a privilege, and also consider myself extremely lucky that I was be able to come to your beautiful country and also come and visit Bangladesh. So yeah.
Please.
Yeah. So then, and then also, of course, when Professor Hasan Masud asked me to join your webinar, and he said, let's talk something about arthroplasty. Then, of course, like, I mean, I know all of you are very learned and have done so much of arthroplasty. I don't think there's very much that I can teach you, but I just wanted to share an experience which I had. Now, even like in Bangladesh, I think even Sri Lanka, most of our knees are osteoarthritic knees. And then on and off, we suddenly have this rheumatoid knee coming, and then sometimes we get stumped, if I can talk in cricketing parlance. So, and then you need to sort of rethink and see, okay, rheumatoid knee, is it different to the osteoarthritic knee? And I think very recently when I had a rheumatoid knee, and then before the day of surgery, I had to sort of revise and just go and think about the rheumatoid knee, because it is not as second nature as the osteoarthritic knee. So I'll just start my presentation. Sorry, okay, so basically, hi. So rheumatoid arthritis, I think all of you all know, is a complex condition that is characterized by chronic inflammation. It's essentially a soft tissue problem. Rather than a bone, it starts as a soft tissue inflammation, and then later on it starts becoming bony. It's about 1% of the adult population, and of course, as a female preponderance. As I said, majority of patients have a secondary deterioration of the cartilage, and that can lead to permanent disability. And of course, because of the soft tissue condition and because it's a systemic condition, it causes more morbidity and of course some mortality, much more than the normal osteoarthritis. Now, I think all of us know that it's usually a small joint disease, which later on goes on to medium and large joints. The majority of our patients have small joint, and they obviously say that they have early morning stiffness in their fingers and in their feet. But of course, later on, they start getting pain in their knees, ankles, and wrists. Later on, of course, the hips are affected. But it's mostly small joints, with later runs up into the major joints. So these are schematic picture as to what happens. That's the normal sort of joint that you can see on your left-hand side. But on your right, you can see the bone erosions, the inflammation, and of course, joint space, which is reduced. And of course, the cartilage bearing away. Now, the X-ray picture, I have the normal joint right on top. We are very familiar with the osteoarthritic joint. But of course, in the rheumatoid joint, we find that there is a more sort of, we see that you have lateral and medial condyle, both are equally affected. And also we find that the subchondral bone is also very sort of, you feel the the bone is also affected there. And then the joint line is reduced on the lateral and medial side both. You don't see as many sort of osteophytes as you see in osteoarthritis, but this is the fact that you have that subchondral area is very, doesn't flare up, shows that it's more rheumatoid rather than osteoarthritic joint. Right. So that's introduction, which is very sort of basic. So what are the problems that we encounter when you think about replacing the rheumatoid joint, rheumatoid knee? Now, I just want to say that total knee arthroplasty is known to be the most successful procedure in advanced knee rheumatoid arthritis. So it is the answer to rheumatoid knee. But of course, to do that, we need to know the disease and understand that rheumatoid arthritis is essentially a soft tissue condition that affects the joint and bone, as opposed to osteoarthritis, where it's a more joint and bone disease, and the soft tissue becomes affected secondarily. So it's very important to have a very good preoperative assessment and preparation, and also you need to think about very, very good meticulous surgical techniques, and of course have a plan for your post-operative rehabilitation. Now this is the mantra for any surgical disease, but in rheumatoid knees, always think about it as much as possible. Right. So what are the possible preoperative considerations we need to think about? Now, if you look at the patient population who come for replacement in rheumatoid arthritis, we find that they are probably about 10 years younger than your normal osteoarthritic knee, because younger people get affected and they have pain, and they are usually they come in their 40s rather than in their 50s and 60s who we encounter in osteoarthritis. And if you look at Dr. Ranawat, who is of course like the godfather of knee replacements, he said that resulted in 93 cemented knee replacements, patients younger than 55, there were 80% were rheumatoid, while only 20% were osteoarthritic. And hence, we need to tailor our counseling and patients' expectations accordingly. Now, what are the counselings we need to see? Obviously, we all know about the longevity of a joint. We can say it's about 15 to 20 years. So if you have a patient in their 40s, we need to counsel them and say that there is a possibility that you might have to revise this surgery. When it comes to osteoarthritis, we can buy time and say that, okay, and you're in your 60s, you probably this is going to be your procedure. But in rheumatoid arthritis, we might have to undergo a revision procedure because we are offering this surgery to you at a young age. And we also need to give the patient a realistic expectation of the activity level. Now we know in a 60-year-old patient, obviously even in Bangladesh or Sri Lanka, they basically want to do their day-to-day course. They need to go to their religious place of worship. In Sri Lanka, it's their temple. In Bangladesh, it could be the mosque. They just need to do some ideal things. But when it's a 40 to 50-year-old person, the person is probably in his prime of life and he needs to do a lot of activities. So we should have a realistic expectation on the activity levels. You might want to do some sports. You might want to do some sort of activities which need knee bending and things like that. So it's very important in rheumatoid arthritis, those patients who tell, hey, okay, we are going to get your knee replaced, but that does not necessarily mean that you can do everything that you wanted to do, and give them a good expectation of the activity level that they can encounter. Then the next thing is, as I said, this is a generalized disease. So you're going to have multiple joints involved. So it's not common, but you can have reasonable chance that the hip on the same side is also affected. Now, what do we do first? Are we going to offer the hip replacement first, or are we going to offer the knee replacement first? Now, if you look at it, people who do hip replacements and knee replacements, we know that when we are doing a hip replacement, we might have to sort of bend the knee in different manners when you're dislocating the hip, and also it might have to sort of get a good arc of rotation. So in which case, I think personally, I would think doing the hip replacement first will be technically easier, and then go on for the knee replacement if the patient has got hip and knee both are involved. And also when it comes to rehabilitation, if the patient has got a diseased hip, if the patient underwent knee replacement, he might not be able to get his arc of motion properly. So, but if his hip is fixed first, then the post-op knee rehabilitation of your knee is probably better. So I personally feel that doing a hip replacement followed by the knee replacement is the better option. And we all know that 80% of patients with rheumatoid arthritis have cervical spine involvement, especially at the atlantoaxial joint, and you can have instability. Most of the time we do our replacements on the spinal, but if we ever have to do it under a general anesthesia, always make sure that we have secured the cervical spine, especially in rheumatoid arthritis. Right. What about imaging when it comes to surgical planning? Now, we all usually get standing x-rays, but when it comes to rheumatoid arthritis especially, I think getting a long leg film can be beneficial, because sometimes we might miss a stress fracture because the patient is walking on a skewed joint, and that can cause undue stresses in the distal tibia. And you don't want to come into in a pre-op x-ray suddenly find a stress fracture in the x-ray after you have replaced a knee doing a normal sort of normal primary, and then that could be a disaster. And also, we also know that in the bone you have a lot of cyst formation, and you can have bony collapse. So sometimes it might be worth, if you need to get augments, if you need to get different add-ons to your primary knee, then it might be worth getting a CT scan. Although personally, I have not encountered that, but having a CT scan might be helpful, especially if you need to plan and get things, or if the patient needs to buy it. Right, now that's another important thing that we need to know. As I said, rheumatoid arthritis is a systemic disease, and then the patient is on treatment for that. And it's important that the treatment continues after surgery. But of course, some of these medications can interfere with our surgical surgery, especially it can cause problems with our soft tissue, it can cause problems with platelets, it can cause problems bleeding. So there are few things that we might have to know about medications, especially when do we have to stop these. Now, NSAIDs are the commonest medications which are used for pain, and the recommendation at present is to discontinue it 5 days, 5 half-lives before surgery. Now, my next slide, I will speak about the common NSAIDs. So NSAIDs, as we know, they affect the cyclooxygenase pathway. The selective ones like celecoxib don't really affect it, but the normal older ones, they do, and that can cause problems with platelets. Aspirin, 7 to 10 days before. Corticosteroids, that's the problem one. Now, corticosteroids, as we know, we don't like to operate on patients on steroids, but some of these patients do have to be on steroids because of the rheumatoid arthritis flare-ups. Now, it's important that we understand that when you have on steroids, your soft tissue, your skin is going to become very, very fragile, and they can cause breakdown of skin and infections. So you need to keep that in mind and have a chat with your rheumatologist and see whether we can reduce that. But the other side of stopping steroids is on steroid-dependent patients, suddenly you can develop an adrenal crisis if they lack their steroid input. So keep that in mind. Methotrexate is used a lot, and at the moment the recommendation is to continue with the procedure, but withhold one or two doses on patients with poorly controlled diabetes. Now, all the other ones are quite technical ones. I don't want to go to them in detail, but there is a sort of a protocol as to what you can do during the surgery, and most of them you need to stop 1 or 2 days before. Right, now, these are the common NSAIDs. So I think ibuprofen in Sri Lanka, we use a lot of ibuprofen and diclofenac sodium. Now, those they recommend at present to withhold 1 day prior to surgery, and those who use naproxen, they tend to use it 4 days before surgery. So that's just a slide as to the common NSAIDs and when we should try and stop before surgery in order to ensure that the platelets and the cyclooxygenase does not get affected. Right. So now what are the intraoperative and technical considerations we need to think about? Now, it's always good to run these things in your mind beforehand so that you don't want to fall into problems, because if you don't think about it, you might have problems. Now, we all know the bone quality is poor in rheumatoid arthritis patients. We all know the bone cuts like cheese. This can be due to the inflammatory disease process itself. It can be due to the chronic steroid usage. And also they think that the synovium produces a lot of prostaglandins, and those prostaglandins also cause subchondral bone resorption. So the bone quality is going to be poor. Now, because of that, we have to be aware that sometimes we might have problems with fixation, and we might have problems with getting a good subchondral bony platform to fix our devices. So we might have to use some constrained things like a stem, as Professor Masud very nicely elaborated. We might have to use a stem at times, and we might have to use bone grafts at times. So it's always good that you have to keep these things available, at least, even if it's not in the hospital, we should be able to get it down as soon as possible if these things are, when we're operating on rheumatoid knee. Now, that's a typical picture. So you're going to have this bone cyst, and you're going to have this, so these need to be addressed. So we'll talk about them later. Now, what are we going to do with these cysts? Now, these cysts need to be filled up, and it's important that most of the time we can use our bone cuts, or we can use some of the cancellous bone, and we can sort of pull them into, we can put them into the uncontained bone defects. But at sometimes, if they're quite big or quite large, we might have to use supplementary fixation things. So like we might have to use augments, which are fixed onto the tibial trays. So as a policy, it's good that if we should at least be aware of these. And if the patient or if the hospital can afford it, it's good to bring them and keep them in the theater, because if we need them, we can use them. So I would think it's best that when you're operating on a complex rheumatoid knee, have the entire gamut of implants available, because that will save you a lot of headaches, and also save all your bone cuts, because all of them can be used as bone grafts. So this is something that I had to do the other day. So we had to use a stem, and also we had to put a condyle. So I used a femoral condyle part and fix it into the bone gap there and put 2 screws. So this is something. Now, of course, when you have, sorry, I'll just go back to the slide. When you have used bone grafts, it's very important that you ensure that the bone, the component and the bone, that surface is well fixed. So it's good to use an augment if you're using a lot of bone grafts, and using a stem have a very low threshold of using stems, especially when you're using a lot of grafts and have to graft the bone. Right. So once again, soft tissue is again the problem that we encounter. So the soft tissue is the real diseased part of the bone, of the knee. So it's important that we have meticulous soft tissue handling. As I said, as Professor Masud said, we are probably going to encounter attenuated ligaments, especially the MCL and the NCL can be attenuated. And of course, as a policy in Sri Lanka, we always use posterior stabilized knees. So it's not because that's the company that is there in Sri Lanka, we use Zimmer. So we have always PS, we don't have really CR retaining knees, we have only posterior stabilized knees, or posterior knees. So we always take the ACL and the PCL off. But in rheumatoid knees, it's always good to have them because most of those ligaments can be attenuated. Now, as I said, most of the time we can get away with normal standard components, but when it's in a valgus and a varus deformity in rheumatoid arthritis, which are correctable passively, still we can get away with normal components. But we know with time, the varus and the valgus sometimes becomes fixed. Now, these are the ones that we need augments, and we need to have the stems. So those patients, make sure that these are available during surgery. Now, the problem with bony deformities, we know that getting the correct rotational alignment of the femoral prosthesis is a key component when it comes to knee replacements. And if we go to our basic knowledge of knee replacements, what do we use? We either use the posterior condyle or we use the trans-epicondyle line, or known as a Whiteside line. Now, when it comes to rheumatoid knees, especially if there is a valgus component, then we know the lateral condyle can become hyperplastic. So if you are going to use a posterior referencing system, we might end up having a more valgus rotation. So it's always good that we either use the trans-epicondyle line or use the tibial cut as the rotational thing, so that we don't fall into this trap. So I think it's always try and use the trans-epicondyle line when you're going for your femoral rotation. And also when it comes to taking your tibial plateau cut or tibial cuts, it's probably sometimes you might have to sort of try to go a bit of an imaginary convex lateral tibial plateau. Otherwise, you might end up taking off more bone. So sometimes you might have to keep the stylus a bit, 1 or 2 centimeters a bit higher than its normal plane, than the normal bone. Otherwise, you might end up taking out too much bone and you might have to have a very small tibial component. The two deformities that we are going to usually encounter is fixed flexion deformity and the fixed valgus deformity. Now, these are two problematic deformities that we might encounter when it comes to a difficult rheumatoid knee. Now, the usual recommendation in a severe fixed valgus is, in a severe fixed flexion, is to treat the patient with serial manipulation and casting a couple of times before the day of surgery. So I had to do it once where we put the patient on a plaster and got the patient down every week and tried and correct at least some amount of the fixed valgus by manipulation and casting. But of course, the other thing in surgery itself, when you need to address the fixed flexion, what we tend to do in normal surgeries, we go for an additional femoral cut. But the problem here is sometimes it's better to try more posterior soft tissue releases when it comes to rheumatoid arthritis, rather than simply trying to remove the distal femoral bone, because if you cut too much of bone, you can end up with having a big mobile knee and you can have mid-flexion instability. So it's probably better to try and do as much as soft tissue releases more as possible, rather than try and do a distal femoral cut, an additional distal femoral cut. Yeah, so that would increase the joint line and may cause increased instability. The other point that we need to remember, which I came across when I was reading, was that in osteoarthritis knee, when we have a fixed flexion contracture, we try and correct it 100% on table. But in rheumatoid arthritis, this is not really necessary, because you might not be able to correct the entire thing during the procedure or the surgery itself. And they say that you can improve the fixed flexion, even 1/3 of the original fixed flexion could be corrected by having a good post-operative rehabilitation or with physiotherapy. So you might not want to do too much of cuts because you can improve, you can get some improvement with physiotherapy post-operatively. So try and minimize your femoral cut as much as possible. Do a lot of soft tissue corrections by doing the posterior releases and see whether you can correct it. But if you still have a bit of fixed flexion, you might be able to correct it with some physiotherapy. So that's what I found in, I think, Dr. Ranawat's lecture series. So he said its contraction is mainly because of the inflammation of tissues. It's not due to the bony deformity. And then if the fixed flexion is less than 15 degrees, it's just a straightforward normal cuts and posterior releases. And 15 to 45, you might be able to do a bit of distal cuts, but try to avoid it. If it's more than 45 to 60, use preoperative manipulations and casting, and use a posterior stabilized knee because that gives better fixation. And also if it is more than 60%, use a constrained knee, which is during a surgery. Now, this is the other big problem that we're going to encounter. As we all know, when it comes to valgus knees, most of the valgus knees are rheumatoid. In Sri Lanka, most of the valgus knees tend to be rheumatoid, while majority of the osteoarthritic knees are varus. And these basic things we know in a fixed valgus is the lateral structures, which are the lateral collateral ligament, the iliotibial band, the joint capsule, and the popliteus. These are the ones which are contracted as opposed to the relatively lax medial structures. Right, so technical aspects that have been recommended is because if it's in a valgus knee, when you're starting off, if you're using an intramedullary femoral insert, try and get the alignment guide about 5 to 10 millimeters medial than you would usually do in a varus knee. And also overcorrect the setting of the valgus angle in your femoral cuts by 3 instead of the normal 6 to 7% that you would use in a varus knee. And also when you are using, I think I mentioned this beforehand, when you are aligning your distal femur cutting guide, you use the epicondyle axis instead of the posterior condyles, because most of the time the lateral condyle is hypoplastic. So that's what, again, Professor Ranawat was balancing techniques in the valgus knee. Again, these more for the not for the consultants, but for the beginners. So basically, you use your tibial cut first, then check your extension gap, and then do your soft tissue releases. Check your flexion gap. You might have to do femur cuts, but always beware, don't cut it too much because you can end up having a laxity in your midflexion. So what about the extension gap balancing? Release your posterolateral capsule. That's the one that gives you a lot of release. And sometimes you might have to pie crust the iliotibial band. And now that's the picture. So we all know what's there in the posterior lateral corner. We have the popliteus tendon, we have the peroneal nerve, and we have the lateral collateral ligament. So keeping that in mind, we need to release the posterior capsule, especially posterior lateral part of it. And we have also a picture of pie crusting of the iliotibial band. I usually put the lollipop in there, and then once I do that, I use the crust. That's what I use. But of course, you might have your own individual technique. But that's what is there. And then that's what you want to achieve. You want to achieve a nicely parallel rectangular bone cut so that you can do a good knee replace. We can put a knee components. Now, talking about synovectomy. Now, synovectomy is also a part of, as I said, a part of your soft tissue, and anyone who has done rheumatoid knee knows that there's a lot of synovium there. Now, what do we do with the synovitis? How do you treat synovitis? At the moment, there is no standard treatment protocol surgically. But if in the presence of active inflammatory synovitis, it's important that you do a complete synovectomy. However, if there is not much synovitis, there is a school of thought that doing synovectomy can cause more of a fibrotic reaction and can end up in a stiff knee. So it might be, if the patient has not much synovitis as a preoperative, he doesn't have too much pain around the knee and doesn't have large amount of soft tissue, you might not want to take off everything and out. But if the patient does have active, lot of swelling and lot of soft tissue, you better take it off. But trying and taking out each and every part of it can induce a fibrotic reaction. I think this picture was already put on there, so I don't need to talk about it. There's always an eternal debate whether we should use a posterior stabilized or a cruciate retaining knee. But of course, as I said, there are two schools of thought. The controversy has been going on, but the problem I need to tell you is that in rheumatoid knees, it's a soft tissue problem. So that more often than not, your ligaments might be involved, in which case we might have to take it out. So it might be having a good idea to always have a posterior stabilized knee rather than think about a cruciate retaining knee. But of course, Scott et al. Has argued that 95% of the time rheumatoid patients undergoing knee replacement, the PCL was intact, and hence why not preserve it to minimize the tibial rollback and subsequent knee flexion. Fixed bearing as opposed to mobile bearing, I guess again the controversy is there. We don't know what is best, but of course I think if there's a lot of deformity, it's probably better to always think about a fixed bearing knee, because we all know that it's much more stable. But of course, in a straightforward rheumatoid arthritis knee, I guess a mobile bearing does not have any problems. It all depends on what you're more comfortable with, and what you're going to, what are the implants which are readily available. But I think that if you think you need to use constrained implants, you need to use augments, obviously, then of course a fixed bearing knee is what you're going to have. Patella resurfacing. In Sri Lanka, we don't use patella, we don't resurface, or we don't use a patella much. Lot of controversies. There is nothing I went through the papers, the literature, there is nothing to say that you need to resurface it, or whether you should or not do it or not in rheumatoid. At one place, they say that most of the people do well without resurfacing, and there is also a chance of recurrent synovitis if you try and do unnecessary procedures. Right, so complications, obviously these complications are common for most people with after knee replacements, but of course, you need to be aware that the soft tissue and the skin conditions are poorer in rheumatoid arthritic patients, so there's a high chance of complications. Now, the important thing to note here is that your medications need to be continued after operation, after your surgery in rheumatoid arthritis. Now, we all know that patients after your knee replacements in osteoarthritis, if it has gone well, the patient does not need any more painkillers. But in rheumatoid arthritis, because there is a generalized disease condition, the patient should be counseled that the patient needs to continue with his or her rheumatoid arthritic medications. And also because the bone quality is soft, we might end up having a periprosthetic fracture. So it's always good that we counsel the patient and tell the patient these things can occur, so be careful. Now, if you look at an outcome, these are papers which came out very, very recently, and it says that this Dr. Gregory Weiss has done a cohort study where he has compared almost 4,000 patients with rheumatoid arthritis who underwent a primary knee replacement against 120,000 patients who underwent knee replacement osteoarthritis. And the results they found was that most patients, they had very good satisfactory outcomes. But of course, there was a higher chance of prosthetic joint infections in rheumatoid arthritis. And they also found that when it came to mortality, the 1-year mortality in rheumatoid arthritis patients was higher, and that was statistically significant. They found that glucocorticoid use and high disease activity scores were most strongly associated with prosthetic joint infections. So, which is, I think, obvious. So the only thing that we are worried about is there's a higher chance of prosthetic joint infections in rheumatoid arthritis. So it's important that we need to make sure that we take all the procedures, proper procedures for that. So despite such complexities often encountered in rheumatoid arthritis, a well-timed, well-executed knee replacement has been proven to improve the overall function and quality of life of patients with disabling rheumatoid arthritis of the knee. So that is this is a very good treatment, but I think it's important that as a surgeon who is executing this surgery, that we need to be aware of the possible problems that we are going to encounter and be making sure that all the necessary armamentarium and the components are available so that we don't fall into problems. Thank you very much.
Thank you, sir. Thank you for your nice and elaborate presentation on rheumatoid knee. It is very much helpful for us. We are going to request our Honorable Professor Dr. Amjad Hasan, sir. Sir, can you share your screen with us? And after that, we will go for question and answer session. Now, I would like to request Professor Amjad Hasan, sir.
Thank you, Tanvir, for your introduction. And I'm going to show you a few cases which we have done over here in Bangladesh. This is a 54-year-old female, a known case of rheumatoid arthritis. You can see the toes, you can see the hand deformity, you can see the, deformity and the foot deformity. So next slide. So very difficult case, very difficult to decide what to do. And this is the preoperative imaging, you know. This is the preoperative imaging, how much in CT scan you can see. Also, you can see on the outer aspect that how much the tibial compression or tibial condyle has been damaged. Bone loss is there, and it is really difficult to decide. And then yeah, bone is also very much porotic because this lady has been having long ago with a lot of steroid preparation, and then the bone becomes so porotic as it is described by Dr. Shivantha, that bone and soft tissue all becoming fragile and very much difficult to manage. So bilaterally, this is a case of bilateral problem. So next slide, please. Next. So this is see how the bones are so much, deformed. Can you go back? Can you go back the slide? Yeah, go back. Yeah, you can see that the perioperative, the bone becomes so much fragile. No. The next one. Yeah. Keep it here. So you can see how much the bone loss is on the outer aspect, and then see bone becomes so much porotic. The soft tissues are also, you can see the cystic, as it has been shown by Dr. Shivantha. Some cysts are also present over there. So all this is becoming very difficult to decide how can we proceed. Next one, please. And yeah, next slide. So this is the lady. The one is done from tissue synthesis. Another is by Smith and Nephew. No, another is from other company. I forgot the name. I think that is not GMAT. Another company. And then bone is, you see the screw has been given because of the soft tissue, because of the law, you have to reconstruct that portion. So there is the screw and the cement has been put over there because of to reconstruct that bone loss. Bone defect, yes. And next one, the lady is walking, you see. Walking with and this is The 4-5 years follow-up, this is 2 years back. And next is again, next one, next slide. This is the situation. She came just a few months back, I think 2020. And then now you can see this situation, the medial condyle of femur has been totally periprosthetic fracture, total devastation. So this is the situation, probably as it is described nicely by Masud, Professor Masud, that how the CCK or the hinge or the stem or augmentation could have been done over here. So this is our experience because we are not been experienced so much. So you can see that the deformity now, and I'm really very, very afraid to put any hand over there because this is a real, totally a devastation for a surgeon and for a party. But the other knee is doing well. Still really difficult, very painful, very prosthetic fracture now. So I'm waiting what to do next. Next case, please. This is 5 years follow-up, yeah. This is another case. You see, as it has been said by you people, both Masud and Shivantha, that in rheumatoid arthritis, it has been Dr. Ranawat and other people have said when it is less than 53 or 55 years, so the rheumatoid arthritis is to be think of. And osteoarthritis more than 60, 65, 70 years. And here you see another lady, 53 years, a rheumatoid arthritis case, preoperative X-ray, the same on the lateral side. The bone loss is over there. The bone stock is not in tibia, but the femur is maintaining. No, not, I think, I don't think it's so much hypoplastic femoral condyle on the lateral side. The next one, please. So this lady, the operation done in 2014, and immediate post-op. Still, she's doing well. She doesn't have any problem. We are in touch with her, and she's good, bilateral done, and still till today we haven't any problem from her side, because you see there it is said that the management also depends upon the deformity. When the deformity is so much, very much deformed, other parts, other joints are involved, and the soft tissue and other parts find very much. In that case, it is very difficult to maintain, and periprosthetic fracture, and particularly when the patient is not working for a long time, becoming so much porotic, every possibility of periprosthetic fracture or other fracture, yeah. So I'm happy that this lady is doing well. Next case, please. Oh, this is 5 years follow-up, yeah. So, yeah, 5 years follow-up. She's doing good. She's working alone, and this is doing well. Both knee. Next, this is from depoisynthesis. Oh, that case was a striker. That I'm forgotten. That case from a striker. That one side is striker and one side and one side was from depoisynthesis. The 75 years old lady again, rheumatoid arthritis. You see, this is she's 83 years old, and she was the first. I mean, this metropolitan magistrate in Dhaka, and chief metropolitan magistrate. She was the first chief metropolitan magistrate. At the age now she's around 78 years or around 80, and you see bilateral, and also she is having, I think she's having some blood problem because what do you call this, hemophilia B trait, thalassemia B trait, yeah. So all the time her hemoglobin also low, around 9 to 10, not above 10. And also she's been suffering for a long time with rheumatoid arthritis, and having a lot of drugs, anti-rheumatoid drugs, even DMA, RD, all this has been taken, steroid. So, but luckily she's a very long lady with 5 feet 7 inches height, but weight is really good, with 60 to 65. That is the positive side for her. And next slide, please. Next slide, yeah. She has swelling. You see, this is what just now Shivantha said, that the inflammatory process is going on, this synovitis and the synovial tissue